to you for
Thank you.
a short sum up, please.
Oh, and it's not a summary. I was going to try to comment on some of the wonderful themes that you've presented, Judy. I thought that was just an excellent presentation on the difficulty of advocacy and policy, and suggests that one of the ways we measure the value of policy interventions is on the actual improvement in health. So we can measure numbers of visits, we can measure dissemination of a report as we must. We can measure our visits, our engagements, the legislation we passed. In the end, it's about health. And, well, let's see here. There we go. Today, I'd like to just, in this summary conversation with you all, offer some observations on the environment that I have suggested Bone and Joint Decade version 2.0 now finds itself. Accomplishments and successes that will drive us forward, and the challenges that I certainly see ahead. You'll see that policy to me is the essential link between science and finding science in the delivery of human health. And without policy interventions in a number of ways, many of which we've heard about today, what we learn in science and what we do in the forcing of translational research in today's environment does not find its way to the care of an individual. You saw this morning that it was social reforms here in Sweden that allowed people who were disabled by law to go back to work and not risk losing their disability. If we only had that in the United States, that is an enormous policy victory that if the decade took one thing and moved it forward, every country should not have a disincentive to returning to work for someone who is disabled. We heard that the registry studies tell us what the return on health has been in biologics interventions and replacements. And we understood something else that was said this morning, that if you have people perform well in PE, it could have downstream sequelae positive effects in human health. What does that mean for physical education and investing? I heard this morning, I think on the news, that 65% of American women are in a plus size. We need PE. And what does that mean for arthritis? In the United States, the CDC has just brought in a policy person at the highest level as a deputy director. Before they lobbied. Today, the CDC is looking at the intersection of public health, clinical delivery of care, and the new intersection of both of those that's unavoidable. They've also looked, and the new director is very attractive to examples of how policy interventions have changed human health. Smoking, seat belts, trans fat. Tom comes from New York, where they took trans fats out of the diet. What can you do on the policy arena to change human health? And of course, I won't spend any time in this lecture talking about healthcare reform in the United States, but this is the big question for us. How will the policy levers of healthcare reform affect the people with chronic disease, our access to care? Will 32 million Americans essentially, we must change the care delivery system to have it delivered in new ways, such as those Peter Brooks spoke about. We're going to measure quality in new ways. It's unavoidable. We'll look at reimbursement, what gets paid for and why. Medical economics have never been more important to help us advocate for policy change in the United States, and I'll suggest globally. And we have to look at medical innovation, the next biologic, and paying for it, not through the lens of cost containment. We've lost a battle globally if that's the way we view access to phenomenal drugs. So, observations on in the environment. Disruptive innovation is before us. Extraordinary discovery is defining rheumatic disease. I love the term auto-cure. I had not heard that. That is just tremendous. All of this means nothing without access. And as a group of committed public servants, we cannot talk about access without coupling it with equity, both within our own nation and globally. To think there's one rheumatologist for 164 million people in Nigeria just makes everybody else's problems pale. Policy changes require data. You heard that this morning. It's time of patient centricity. You've heard it all day. We've moved from a time of paternalism in care to a time of extreme autonomy where we felt patients' rights and privacy and HIPAA and interglobal privacy laws were required, to a time that the patient understands the power of their data, the desire to have that data shared not just locally but globally, to be part of that large cohort that has to then drive back to our new understandings of personalized medicine and what works in comparative effectiveness, what works for what patient at what time. We can't have population-based comparative effectiveness, or those of us with the HLA-B27 antigen might not have gotten a biologic as soon as we did. Many have said we're the new biocitizen that will find our policy work through Twitter, Facebook, Patients Like Me. If you've never looked at that site, you must. We're in the era of the science commons, and the public knows this. The funding public wants to see pre-competitive sharing of data. I've heard recently about open source clinical trials. Imagine a future where the public says, de-identified, I want this data to go into a broader research portfolio. Huge, huge questions that are not just local, they're global. Public access, transparency. You spoke to a beautiful IOF plan, and I wanted to make sure that many of you look at a recently launched National Osteoarthritis Public Health Agenda by the CDC and the Arthritis Foundation. Just go to CDC or Google CDC Public Health Agenda Osteoarthritis, and you'll see something that mirrors the kind of policy demands that you're suggesting. Global equity, I've mentioned. The idea of finding microcosm communities that mimic a country. I was in Akron, Ohio last week, and Akron, Ohio is not a large city. It's been struck by a lot of economic decline, but they know that the data on their city, and they have 90% of the people soon to be enrolled in a system-wide health network, mimic the United States in 5 major chronic diseases. Could we find those communities and make them part of a global surveillance network that would come out of what I call the Bone and Joint 2.0, being the Uber thought leader for policy change across the globe? And who are our global funders? Where's the Wellcome Trust in what we do? So, challenges to make the economic case, as we've heard this morning, that innovation is not a question of cost containment. It's about human life, it's about access, it's about equity, and we need the economics, and many of them we've heard about today. We are in a time when we must embrace chronic disease generally. We're going to be part of this. We can't turn away. Fortunately, in the United States, arthritis hit the high note along with diabetes and cardiovascular disease as what the Senate saw as the 3 pooled areas. Within that, arthritis must demonstrate that all of your risk factors for other chronic diseases begin with whether you're in so much pain that you can't exercise. Final thought, this is me in 1984. After a very long hospital stay, 18 days, when I was convinced I would look like the man that I had seen in 1978 curled over with ankylosing spondylitis. You all know the picture well. I'm grateful today to have gone off of disability back to work because of Enbrel. Quite aware that this is a complex molecule, it's terribly expensive, my access is precious, I am uninsured. Only can get insurance in the United States by working. So these realities of what our healthcare reform is somewhat about this journey. Tough questions, the safety of this molecule, the safety of generics wherever they're produced. These are questions, policy questions. Do I want to be part of the discussion on the risk-benefit of this drug at the FDA table? You bet. And do I think my voice is more important, in fact, for the FDA to hear that I want the benefit of this drug to be weighed against the risk so there aren't any quick knee-jerk decisions to pull the drug off the market because we see a little elevated risk of lymphoma? Ask me what the quality of life change is about. So, some observations I've been very pleased to be asked to share today. Thank you.
Thank you. Thank you very much, Deborah.